Thank you, Ajanta Pharma, and thank you, Dr. Lalit, for giving me this opportunity. You have done a nice cataract surgery, no complication, and next day patient comes to you, he has an hypopion, a fibrin membrane. Now, the biggest dilemma is what to do. Whether it's an infection or an inflammation, because the treatment is diagonally opposite. In inflammation, you need to load the patient with steroids, and in infection, you need intravitreal antibiotics. And delaying a situation, if you have an infection and if you delay, you can lose the eye. So this is what I will be talking is post-operative reaction, infectious versus inflammation. The problem, if you have this inflammation, the problem is lab investigation like culture will take 48 hours. Only investigation that can give immediate result is gram staining and KOH, and this is not available with most of us except institutes. And decision making is essentially clinically. Now there is a newer investigation, what we call as an rapid genotypic antimicrobial test. This detects gene by PCR. Results comes within 2 to 6 hours and identifies which antibiotic it is sensitive to. So if you have an access to Argen, you can go ahead and take a tap, and you can know the sensitivity of the organism. Coming again, I'll be discussing my talk under this headings: history, symptoms, signs. These things will I'll be dealing individually. If you have a patient of inflammation, a careful history should be taken about pre-existing disease like uveitis, a general condition of look into it. And if you are not an operating surgeon, you should take an history from the operating surgeon about the and the complication what he had during surgery. Because if you have an excess manipulation during surgery, it can manifest as an inflammation, and these patients only require does not require intravitreal injections. Uh, सडनली ए पेशेंट कम्स पेशेंट कहता है डॉक्टर साहब कल तक तो ठीक दिख रहा था रात के 2 बजे मेरी नींद खुली आंख में दर्द था और मैंने आंख बंद करके देखा तो मेरी रोशनी खत्म हो गई इफ ए पेशेंट कम्स विद दिस काइंड ऑफ हिस्ट्री पेन एंड लॉस ऑफ विजन it's diagnostic that you are dealing with endophthalmitis. It's nothing else. Don't err in favor of inflammation. Go ahead and give intravitreal antibiotic. But this pain is not a cardinal symptoms in all the cases. It occurs in only 70% of cases. Good vision usually occurs in sterile and poor vision in infective patient. So go ahead and give an intravitreal injections. If you have an angry looking eye like this with a lot of chemosis, uh, pain, then err on the side of infection. Intraocular pressure is high in sterile inflammation and is low in infective patients. Wound integrity should be checked if you have an phaco burn, open wound, or a vitreous in the wound. Definitely, you are on the side of infection. If you have an exudates like this, then it's a definite sign of infection. Or if you have an blebitis, yes, the patient needs an intravitreal injection. Hypopion, always you see an hypopion, it's a sign of severe inflammation. Now, this hypopion is infective or sterile. That will, if you have a dark brown hypopion, usually it's sterile. If you have an yellowish white, it's infective. On treatment, if the hypopion increases on morning to evening, it increases, then consider it as an infective and give intravitreal antibiotic. Pupillary dilatation is one of the most important signs. What I do if a patient comes with an fibrin membrane hypopion, I make the patient sit in my OPD, ask my attendant to give half hourly steroids and give mydriatic. If patient dilates or the fibrin membrane breaks, you can examine the posterior segment or you can see the glow. Because glow in sterile endophthalmitis is good, while in infection, you will find exudates into the vitreous cavity. And if you find exudates in vitreous cavity, then it's a diagnostic for infection and you have to give intravitreal antibiotic. If you are not able to visualize the posterior segment, go ahead and do an ultrasound. And if you find exudates like this in the vitreous cavity, it's diagnostic of infection and you have to give intravitreal antibiotic. Coming to tasks, it presents within 12 to 24 hours. There is a limbus to limbus corneal edema, non-reactive dilated pupil. AC reaction is moderate to severe. There is an increased IOP and restricted to anterior segment. Etiology of TAS is not known. So, reaction can be to abnormal solutions, contamination of equipment, denaturated viscoelastic residual detergents, intracameral anesthetic agents, and preservative and topical medication. Consider TAS only if it is not very severe presentation. Response to hourly topical steroid under daily supervision if there is a worsening or on the side of infection, and it is better to uh, give antibiotic or intravitreal antibiotic if the patient is not responding to the treatment. This is one of the patient you can see presented on day one with an fibrin exudate like this. It's white in color, post RK. This looks to be inflammatory. We started this patient on topical and systemic steroids. You can see this fibrin membrane retracting over a period of time, and this patient improved to 6/6 vision. This is one patient. You can see pupil is not dilating. Hypopion is there. We made a diagnosis of endophthalmitis, gave vancomycin with ceftazidime. On day one, you can see there is a patient response. The hypopion has decreased. The pupil has started dilating. And at this stage, we also see a good glow. That means the patient is responding. At this stage, after 1 to 2 days, I generally start my patient on systemic steroids along with antibiotics, and day 10, you can see it's a nicely anterior segment is quiet, the exudates and vitreous cavity is resolving, patient is improving, and this patient achieved a 6/6 vision just on intravitreal antibiotic. This is one of my very interesting patients, no hypopion, and a patient came with day one post-operative came with finger count vision only. I looked at my records. Patient was 624 post-operatively. I couldn't see the fundus. It was a lot of exudates in the fundus. Although there was no hypopion, because there is no red flow and exudates in the vitreous, I made a diagnosis of endophthalmitis, gave intravitreal Vanco with ceftazidime, and this patient improved to 6/6. Because of my early intervention and early diagnosis, I was just able to salvage these eyes on intravitreal injections. Many times, with all this information, you are not able to diagnose whether it's an infection or an inflammation. So, what I do, I make the patient, or if you have a facility of admission, or you make the patient sit in your OPD, ask your attendant to put hourly antibiotic and steroids. If you see there is an improvement in hypopion or inflammation, or on the side of inflammation, but if you see a serial deterioration, then it's an infection. You have to take this patient for intravitreal antibiotic, and please don't delay with intravitreal antibiotic. This is a summary of what I have said. If you have pain, weak wound, hypopion, which is white or brown in color, poor glow, and exudates in the vitreous cavity, the diagnosis is infection. If you have a mild pain, lot of surgical inflammation, good pupillary dilatation, it's an inflammation. Sudden deterioration in vision, bad wound, pain, chemosis, hypopion, poor glow with exudates in vitreous cavity, it's infective. Go ahead and give intravitreal injections. Pre-existing disease like surgical manipulations, complicated surgeries, hypopion, good glow, eco-free ultrasound, it's in sterile inflammation. Wait, give steroids in this patient. Uh, Once you have given intravitreal antibiotic, wait for 24 to 36 hours. If there is any worsening, go ahead and do an past planar vitrectomy. If there's no worsening, continue on medical treatment. And if there is no significant improvement, go for an past planar vitrectomy. If there is an improvement, continue with the medical treatment. Thank you very much for your kind attention.